All right, if you're getting ready for your mental health nursing exams, we are about to dive into some of the toughest topics you're going to face. In this high-yield, no-fluff review, we're covering the essentials of anxiety disorders, trauma, OCD, and all the critical pharmacology you absolutely have to know. So let's get right into it.
You know these questions, right? The ones that can really make or break an exam. Is your patient's racing heart a full-blown panic attack, or is it a PTSD flashback? And what about the meds? Do they need a fast-acting benzodiazepine right now, or a long-term drug like buspirone? By the end of this, you're going to feel so much more confident answering these. So, let's start at the beginning, with the very first step of the nursing process, assessment. Because you can't just jump in with a plan if you don't know what you're actually looking at. These disorders can seem similar on the surface, but they have really distinct features you've got to be able to spot.
Okay, this chart makes it super simple. For generalized anxiety disorder, or GAD, I want you to think about excessive, out-of-control worry about everything: health, money, work, you name it. For OCD, it's all about that vicious cycle, right? You have an obsession, this intrusive, unwanted thought, that causes massive anxiety. And the only way to get relief is through a compulsion, a ritualistic behavior. And then for PTSD, the key is that everything is tied back to a specific traumatic event. The person re-experiences it, they avoid anything that reminds them of it, and their body is just stuck on high alert.
Now, before you do anything else, and I mean anything, you have to figure out your patient's level of anxiety. This is your #1 priority because it tells you exactly what you can and can't do. See, at a mild level, a person's perceptions are actually sharpened. They can learn. At moderate, their world starts to narrow. By the time they hit severe, they can only see one tiny detail and they can't take in anything new. And at the panic level, forget it. All rational thought is gone. You can't teach coping skills here. Your one and only job is safety.
And for your exams, you got to remember these conditions don't just pop up out of thin air. Sure, there's a genetic and a neurobiological piece to the puzzle, but things like childhood trauma, abuse, and violence are massive risk factors. It just goes to show how deeply those early experiences can shape a person's mental health for years to come.
Okay, so we've done our assessment, we have a good idea of the diagnosis, and, crucially, the patient's anxiety level. So now what? Well, now we plan. Let's move into Act 2 and start building our toolkit of interventions, both therapeutic and pharmacological.
This framework right here, trauma-informed care, this is everything. This isn't just a technique, it's a whole philosophy that should guide every single thing you do. You start with the fundamental belief that anyone you're caring for could have a history of trauma. So you realize how common it is, you recognize the signs, you respond with that understanding, and, this is huge, you actively work to resist doing anything that could accidentally re-traumatize them.
And here is a perfect example of what that sounds like in real life. Let's unpack this. I can see this is incredibly difficult for you. That's validation, pure and simple. You're telling them, I see your pain and I believe you. Then, I'm here to help you stay safe right now. Boom. That's your job. You're an anchor of safety right here in the present moment. That's how you start to build trust.
So when a patient is dissociating or flashing back, their mind isn't in the room with you, it's somewhere else entirely. Your job is to be the anchor that gently pulls them back to the here and now. These 3 techniques are simple, but they are so powerful. The 5-4-3-2-1 method is fantastic. You just guide them to name 5 things they can see, 4 things they can feel, 3 things they can hear, and so on. It literally forces their brain to reconnect with the present environment.
All right, meds, you know this is going to be all over your exam, so let's nail it down. SSRIs, like sertraline, are your first-line, long-term choice, but the key thing to remember, they take 2 to 4 weeks to work. Now, for an acute panic attack, you're going to see benzodiazepines, like lorazepam. They work fast, but they come with huge risks, like dependence and respiratory depression. Then you've got buspirone. The great thing is there's no risk of dependence. But just like an SSRI, it takes weeks to kick in, so it is not for PRN use. And finally, beta blockers like propranolol, they don't touch the psychological anxiety, but they're amazing for shutting down those physical symptoms, like a pounding heart.
Okay, if you only remember one thing about benzos for your exam, please let it be this. You never stop them abruptly, ever. Suddenly stopping a benzodiazepine, especially one with a short half-life, can cause severe withdrawal. We're talking seizures. It can be fatal. The dose must always, always, always be tapered down slowly by a provider.
Now you might also see some other meds used in ways that might surprise you. Prazosin, which is actually a blood pressure medication, is famously good at stopping those awful PTSD nightmares. And you'll see anti-epileptic drugs or anti-seizure meds used as mood stabilizers to help with the impulsivity and emotional instability that so often come with trauma.
So how do you help someone who is actively avoiding the very treatment they need? Well, that's where motivational interviewing comes in. It's so cool. Instead of telling a patient what to do, you have this collaborative conversation that helps them find their own reasons to change. For a trauma survivor, this is a game changer for getting them to stick with therapy even when it gets really, really hard.
All right, let's move into our final act, implementation. This is where things get real. We're focusing on those high-stakes situations where a patient is in crisis, and your absolute #1 priority is keeping everyone, the patient, yourself, and the rest of the unit, safe. Look, patients don't just go from 0 to 100 out of the blue. Escalation follows a pretty predictable pattern. The real key here is learning to spot the early warning signs in that pre-assaultive stage. The pacing, the clenched fists, the muttering, that is your golden window. That's your chance to intervene verbally and prevent the whole thing from tipping over into the assaultive stage. Spot it early, and you can often stop it from ever happening.
When you see a patient escalating, these are your first moves. And look at step 1. What is it? Your safety. You cannot help anyone if you're not safe. Always know where your exit is. Keep your body language open and non-threatening. Use a calm, neutral tone. Talk in short, simple sentences, and offer choices. Something as simple as, would you like to take a walk with me, or would you prefer to sit here for a minute, can work wonders by giving back a little bit of control. And finally, call for help early. It's not a sign of weakness. It's a sign of a smart, safe nurse.
And please remember this, you are not a one-person army. You're part of a huge team. You've got therapists doing specialized work like EMDR for trauma, case managers connecting patients to resources, and community support groups. And part of your job is knowing when to call in the cavalry. If there is an immediate risk of harm to the patient or anyone else, you don't hesitate. You activate your crisis team. Period.
And we'll end on this question, because it really gets to the heart of what we do as psych nurses, doesn't it? Everything we've talked about, the communication, the grounding, creating a safe space, using medication wisely, it's all in service of answering this question for our patients. You're helping their nervous system learn, sometimes for the very first time, that it's possible to be safe right here, in this moment. That's the work, and man, is it powerful.